Usually, when we talk about a medical diagnosis, there's this expectation of absolute precision.
Right, like it's math or engineering or something.
Exactly. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, there it is, broken.
Yeah, it's very clean, very binary.
And we like that. We, as patients, really like things to be binary and visible. But today we're taking you into a space where that clean, binary comfort just completely disappears.
Oh, yeah, it vanishes.
We're taking a deep dive into the world of prenatal and fetal medicine. And in this environment, the ethical landscape is just profoundly murky. That standard X-ray machine of medical ethics, it's basically broken here.
It shatters the second you walk into the maternity ward. Because, I mean, in almost every other field of medicine, you have one doctor and one patient.
Right.
But in maternal-fetal medicine, you're dealing with what the field calls the maternal-fetal dyad.
The dyad, yeah.
Yeah. It's this incredibly unique, interconnected scenario. You have two lives bound together in a way that just requires a completely different rule book.
And the mission of our deep dive today is to uncover those hidden ethical frameworks that doctors use to navigate that dyad. Because, if you ask most people on the street about medical ethics, they'll probably just quote the Hippocratic Oath.
First, do no harm.
Right. First, do no harm. Simple enough. But the source material we're unpacking today reveals a world where defining what constitutes harm or defining autonomy is just incredibly complex.
Even defining who the patient actually is isn't black and white.
Wait, really? The definition of the patient changes.
Oh, absolutely. And that's why it's so critical to understand that the guidelines we're looking at, they aren't just abstract philosophy.
Right. This isn't just a thought experiment.
No, not at all. We're looking at the high-stakes, practical playbook used every single day by maternal-fetal medicine specialists, or, MFM clinicians.
So they use these frameworks for real-world situations.
Exactly. Everything from navigating their own deeply held moral objections to mitigating, literally lethal medical biases when lives are on the line.
Wow. Okay, so to understand how a doctor actually makes a decision in that delivery room, we kind of have to start with the foundational forces at play, right?
Yeah, the basic rules of the road.
Right. So there are 4 core principles of medical ethics that govern almost all of modern medicine: autonomy, beneficence, justice, and non-maleficence.
Which are great in theory.
Yeah, but in the context of pregnancy, those forces are just constantly colliding.
The defining characteristic of those 4 principles in this field is that none of them automatically gets the right of way.
Right, there's no default winner.
Exactly. So let's break them down. First, you have autonomy, which is the patient's right to make decisions about their own body.
Makes sense?
Then you have justice, which demands fairness and equality in how care is distributed. But the real friction in prenatal medicine usually happens between the other two: beneficence and non-maleficence.
Okay, so beneficence is the duty to act in the best interest of the patient. Doing good, basically.
Right. But in this dyad, the doctor has a dual duty. They have to act in the best interest of the pregnant person and simultaneously act in the best interest of the fetal patient.
And that runs headfirst into non-maleficence.
Yeah, the duty to do no harm. In the maternal-fetal dyad, doing no harm becomes this massive calculation of proportional risk.
I mean, how does a doctor even calculate that?
Well, think about the mechanics of fetal surgery. Say there's a life-threatening complication for the fetus that can be corrected in utero.
Okay.
The beneficence toward the fetus there is huge. You could save its life. But to perform that surgery, you have to cut into a perfectly healthy pregnant person.
Oh, wow. I never thought about it like that.
Right. You are intentionally causing maternal morbidity. You're harming the mother's healthy tissue to save the fetus.
So you're violating non-maleficence for the mother to achieve beneficence for the fetus.
Exactly. Or take the reverse scenario. Say a doctor decides to withhold a powerful pain medication from a pregnant person because they want to protect the fetus from chemical exposure.
Okay.
By protecting the fetus, doing no harm to it, the doctor is actively causing the mother to suffer.
It's like imagine those 4 principles as sliders on a sound engineer's mixing board.
I love that analogy. Yeah.
Right. You're the doctor, you're trying to get the perfect audio mix for a healthy outcome. But all the sliders are mechanically linked together.
The tethered.
Yeah. If you push the fetal beneficence slider way up to try and save the fetus, you physically drag the maternal non-maleficence slider down, meaning you cause harm or pain to the mother.
That is the exact tension MFM specialists live in every single day. And because that mixing board is so sensitive, Major international obstetrics organizations endorse something called the professional responsibility model.
The professional responsibility model.
Okay, yeah. It's essentially the operating manual for that mixing board. It's designed to keep the doctor from pushing any of those sliders to a dangerous extreme.
So what do those dangerous extremes actually look like in practice?
Well, on one side, you have what's known as fetal rights paternalism.
Okay.
This is an incredibly dangerous extreme where clinical judgment about the fetus is imposed over the pregnant person's preferences.
So the doctor just ignores the mother.
Effectively, yes. It reduces the pregnant patient to a mere container for the fetus. It just strips away their autonomy entirely.
That's horrifying. Treating the person just as a vessel rather than, an active participant in their own medical care.
Precisely. But the professional responsibility model also rejects the opposite extreme.
Which is what?
It's sometimes called pregnant woman rights reductionism.
That's a mouthful.
It is, yeah. But it's basically the idea that a doctor should just blindly comply with whatever the patient prefers, functioning basically like a medical vending machine, regardless of the clinical evidence.
Ah, I see. So the middle ground is?
The professional responsibility model. Right. It dictates that a doctor's obligations must be grounded in evidence-based medicine and mutual negotiation.
Okay, mutual negotiation.
Yeah, it honors maternal autonomy completely while still acknowledging that the doctor has a professional obligation to the fetal patient as well.
So if the doctor is the sound engineer balancing these sliders through negotiation, the most fundamental question has to be, who actually gets to make the final call when things go wrong?
Right.
And, maybe more importantly, when does the fetus officially become a patient that the doctor has an obligation to in the first place?
This is where we get into some of the most profound and, frankly, surprising concepts in the clinical guidelines. The framework uses something called a two-variable activation chart.
Two-variable activation chart.
Right. It defines when a fetus actually achieves full patient status.
Think about how wild this is for a second. We're so used to hearing these debates framed purely around biological milestones, right?
Heartbeats, brainwaves, weeks of gestation.
Exactly. But the medical framework doesn't just use an automatic biological switch that flips at conception. It requires two variables. One is viability, which the medical community generally recognizes around the 22 to 24-week mark, right? When the fetus could potentially survive outside the uterus.
Right, that's the first variable.
But the second variable is maternal conferral.
And it is a massive shift from the public discourse. The empirical data, and this includes recent validations by researchers studying how doctors actually make moral decisions in real time. It confirms that clinicians use viability and relationality to determine moral status.
Wait, hold on. I really want to make sure we don't just gloss over that.
Sure.
Before viability, a fetus's status as a medical patient is essentially conjured into existence by the pregnant person's intention.
Yes.
Like, if she intends to carry to term, the doctor has a second patient. If she doesn't, they don't.
That is exactly the ethical standard.
Yeah.
The mother's intention is the key that unlocks the entire ethical framework.
That feels like a huge paradigm shift.
It is. And the leading medical colleges cement this point unequivocally. Pregnancy does not diminish a person's right to bodily autonomy. A decisionally capable pregnant person retains the absolute fundamental right to refuse any medical interventions.
Even if that refusal leads to a tragic outcome.
Yes, even if that refusal is highly likely to result in fetal harm or death. The pregnant patient always has the final say over what happens to their body.
Wow.
The courts have established a very strong precedent on this, actually. They condemn any kind of court-ordered obstetric procedure.
So you can't force care.
Right. You cannot legally or ethically strap a pregnant person to an operating table and force them to undergo a C-section against their will, no matter what the fetal benefit might be.
So what does the doctor do if they strongly disagree with the mother's choice?
The clinician's role is informed consent. If there's a disagreement, the doctor must use respectful persuasion. They outline the risks, they frame it as an ongoing dialogue, but they absolutely cannot coerce.
So we just talked about how the mother's mind, her intention, is the key to this whole system.
Right.
But that means the entire medical system collapses if the clinician doesn't fundamentally respect the pregnant person's mind. Which brings us directly to the lethal threat of implicit bias.
It's such a vital connection to make. Because if a doctor holds implicit biases about female patients or patients of color, they aren't just exhibiting bad bedside manner.
No, it's way worse than that.
Yeah, they're actively corrupting the very mechanism of autonomy we just outlined.
And the guidelines are incredibly clear about this. Stereotyping female patients isn't just frowned upon, it is a formal ethical violation.
And in many cases, a violation of international human rights law. The frameworks lay out very specific assumptions that doctors must actively fight against in their own minds.
Let's look at how those assumptions manifest in a clinical setting.
Okay, first, there's the assumption that a pregnant patient's emotional vulnerability overrides her cognitive capacity.
What's that look like?
If a doctor looks at a crying, stressed pregnant woman and thinks, she's too emotional to understand this complex medical choice, I'll just make the decision for her.
Oh, wow.
Yeah, that is a direct violation of international treaties protecting women's rights in healthcare.
Then there is the assumption of a default desire for motherhood. A doctor cannot ethically assume that every pregnant person inherently wants to be a mother.
Right. Or that they should prioritize the fetus over their own well-being.
And finally, assuming a patient has a diminished capacity for sound moral judgment just because they're pregnant, that directly violates the ethical principle of justice.
And we really have to emphasize the stakes here. We hear about implicit bias a lot in, corporate training seminars.
Yeah, where it's usually framed as just being more polite to your coworkers.
Exactly. But in a maternity ward, bias is lethal.
Let's put a concrete scenario to this so you can see the mechanism of how bias actually kills.
Ah,
Imagine a pregnant Black woman in the maternity ward.
okay.
She tells the nursing staff that her abdominal pain is an 8 out of 10. Now, if a clinician has an implicit, unrecognized bias that Black patients have higher pain tolerances,
Or that female patients tend to exaggerate pain.
right, they might decide to just offer Tylenol and wait an hour instead of ordering an immediate ultrasound.
And in that hour, a minor complication becomes a catastrophic hemorrhage.
Exactly.
The delay in diagnosis, driven entirely by a subconscious stereotype, becomes the direct cause of death. And, the data on this is just devastating.
It really is.
Recent maternal mortality reports out of the United Kingdom, for instance, they've documented that Black women remain roughly 4 times more likely to die in childbirth than white women.
4 times. That is a staggering systemic failure.
It is. When bias prevents a doctor from listening to a patient's self-reported reality, the dyad breaks down.
So how do you fix it?
Well, the required action from the medical community isn't just telling doctors to try harder. It requires implementing structured debiasing protocols, standardizing how data and pain scales are collected.
Actively challenging these stereotypes at an institutional level before the doctor even walks into the room. Okay, so far, we've firmly established the patient's absolute rights. The patient holds the ultimate authority over their body. But what happens when we flip this around?
Okay, let's flip it.
What happens when a doctor's intentional medical judgment clashes with the patient's autonomy? Not out of bias, but because of the doctor's own deeply held moral compass.
Right.
If a clinician is asked to provide care that fundamentally violates their own religious or ethical beliefs, can they just say no?
They can. But the medical field places extremely strict boundaries around how they say no.
This concept is known as conscientious objection, right?
Right. It is a recognized right, but it is absolutely not a blank check to abandon a patient in need.
The Global Obstetrics Guidelines outline a strict hierarchy of obligations for handling conscientious objection. It's essentially a 3-step protocol. Let's walk through them.
Sure. The foundational obligation, the first step, is to inform.
Okay.
Even if a clinician morally objects to a specific procedure like a pregnancy termination, they are ethically required to inform the patient of all medically reasonable alternatives.
So you can't hide medical options from a patient just because you personally disagree with them.
No, absolutely not. Failing to provide the full menu of medically sound options is an independent ethical violation.
Which makes sense. You can't manipulate a patient's choice by withholding data, so what is the second step?
The second step is to refer. The objecting doctor must provide a timely referral to a non-objecting colleague. The guidelines literally call this the non-negotiable operational floor.
The operational floor, meaning they have to actively help the patient find someone who will provide the requested lawful care.
Yes.
I'm going to pause here for a second because this is where the philosophy really rubs up against reality.
Oh, totally.
If a doctor has a profound, deeply held religious objection to a procedure, forcing them to facilitate a referral still makes them an accomplice in their own mind, doesn't it?
Yeah, for many it does.
So why can't they just say, I object, this violates my core beliefs, and completely step away from the situation?
That is exactly the philosophical friction at the heart of this debate, and it is hotly contested in medical ethics circles.
I bet.
There is a strong camp of ethicists who argue that medical professionals actually have no moral claim to conscientious objection at all.
Wait, none?
None. Their argument is essentially, you voluntarily chose to enter a profession that has known, standardized obligations to public health. If you can't fulfill those obligations, you shouldn't have taken the job.
Oh, wow. So it's like you don't get to be a firefighter and then object to putting out fires in certain types of buildings.
Exactly. However, the global consensus in medicine does not go quite that far. The consensus allows for individual conscientious objection, but it draws a hard line.
Which is?
The doctor's conscience can never become a barrier to the patient's access to lawful care. Which brings us to the top of that three-step protocol, the emergency override.
And this is where the right to object completely vanishes, right?
Yes. Mandatory and unconditional care. If a situation becomes an emergency and a delay in care would jeopardize the patient's life or health, the doctor must provide the care immediately.
No exceptions.
No exceptions. Their personal conscience is entirely overridden by the immediate biological needs of the patient in front of them.
It's also really important to distinguish between one individual doctor objecting and an entire hospital deciding to object.
Individual versus institutional conscientious objection.
Right.
If one doctor steps back and immediately hands the clipboard to a colleague down the hall who steps in, the system still works. The patient gets care with minimal delay.
Sure.
But institutional objection is when an entire hospital network or a regional health facility flat out declines to provide lawful medical services.
And major medical organizations explicitly reject institutional objection.
They do.
Because if an entire hospital refuses care, the burden is suddenly shifted onto the patient. Imagine a pregnant person experiencing a severe complication, needing urgent, lawful care, and realizing that no hospital within a 200-mile radius will accept them.
It creates what health experts call geographic access deserts.
Geographic access deserts. That's a terrifying phrase.
It is, and international human rights courts have ruled on this repeatedly, stating that conscientious objection cannot be used as a systemic tool to block entire populations from entitled health care.
So when you look at all of this, the delicate balancing of the mixing board, the vital need to constantly check your own subconscious biases, the strict limits placed on your own personal conscience, and the constant threat of geographic access deserts.
It's a lot.
It takes a massive psychological toll on the professionals doing the work.
It really does. The field refers to this toll as moral distress. And we need to be careful with how we visualize this, because it's often talked about like burnout.
Right, where the solution is just like a yoga class or a wellness seminar.
Yeah, exactly.
Yeah.
But moral distress is less like individual burnout and more like a glowing check engine light on a dashboard.
I love that framing. We keep trying to treat the flashing dashboard light by telling the driver to take deep breaths when the actual engine under the hood is completely seized up.
Spot on. The visible symptoms are psychological distress and secondary traumatic stress, which research shows is highly prevalent among MFM specialists.
But the hidden roots of the problem are systemic failures.
Exactly. It's caused by institutional barriers that create unclear care pathways, or hospital policies that unnecessarily separate newborns from their parents in the ICU, forcing the doctor to enforce a rule they know is psychologically damaging.
Oh, that would be awful.
And perhaps most significantly right now, moral distress is driven by restrictive statutory legal environments.
And to understand the modern reality of this field, we have to look neutrally at the legal environments dictating prenatal care.
We do.
We aren't making a political judgment here. We are just looking at the jurisdictional realities and the impossible positions doctors are forced into.
The legal landscape is incredibly fraught and geographically unstable.
Yeah.
Take the United States, for example.
Okay.
You have a federal law, EMTALA, which mandates that any hospital receiving Medicare funds must provide stabilizing emergency care to anyone who walks through the doors.
Right.
But in the post-Roe v. Wade, post-Dobbs landscape, that federal mandate is frequently clashing with state-level laws that ban or severely restrict certain obstetric interventions.
Think about the physical reality of a doctor caught in that vice. They have a pregnant patient hemorrhaging. Medical science and federal law dictate immediate intervention.
Yes.
But state law might threaten the doctor with prison time and the loss of their medical license if they intervene before a specific, legally defined biological threshold is crossed.
It's a nightmare scenario.
Yeah.
The doctor is forced to stand there watching the clock, consulting hospital lawyers while a patient's vitals drop.
That isn't just stressful. It is profoundly morally injurious.
And if you zoom out globally, you see how geography completely dictates ethical reality. Contrast the U.S. legal minefield with the GCC, or the Qatar region.
Okay, how does it work there?
Clinicians there operate within an Islamic bioethical framework. Within that specific framework, ensoulment, and thus the full moral status of the fetus, is generally recognized at 120 days of gestation.
Oh, wow. So a specific timeline.
Right. Any medical interventions are heavily dependent on statutory verifications aligned with that specific religious timeline.
So a maternal-fetal medicine specialist today isn't just a clinician. They are expected to be an amateur lawyer, a high-level ethicist, and a diplomat, all while trying to physically keep two interconnected patients alive.
Yeah, it's an impossible job description.
So how does the medical system actually fix the engine to stop that check engine light from flashing?
The leading research on clinician resilience argues that hospitals have to reframe this as an institutional occupational health imperative. You can't put it all on the doctor's shoulders.
Right.
The hospital system itself has to provide structured ethics consultations in real time. They need to facilitate regular team debriefings after traumatic cases.
So the system has to actively support the doctor, so the doctor has the bandwidth to support the maternal-fetal dyad.
Precisely.
As we bring all these incredibly complex threads together, it begs the question, how does a clinician practically hold all of these competing forces in their mind at the exact moment they need to make a decision?
Yeah.
The laws, the biases, the dual patients, they don't just pick one philosophical theory and hope for the best, right?
No, they use a combined approach that the medical community refers to as the ethics toolbox.
The ethics toolbox. Okay, what's in it?
It's an interlocking set of lenses. You deploy the right combination of tools for the right moment. The first tool in the box is principlism.
This is that mixing board we talked about at the beginning. Autonomy, beneficence, non-maleficence, justice.
Right. This tool is used to set the non-negotiable boundaries of care. It helps the doctor mathematically identify where the conflicts are happening.
But rules and boundaries aren't enough on their own. So what's the second tool?
Care ethics. If principlism sets the boundaries, care ethics governs how the care is actually delivered.
Okay.
It grounds the medical practice in relationships, empathy, and dependency. Crucially, it forces the clinician to resist treating the maternal-fetal relationship as an adversarial battleground.
Which seems so important given everything we've talked about. And the final tool.
The final tool that ties it all together is virtue ethics.
Virtue ethics.
Yeah, this isn't about rules or relationships. It is about the actual character of the doctor operating within the system. It demands compassion, self-effacement, and what the ancient Greeks called practical wisdom.
Practical wisdom.
Yeah. And what's fascinating is that this specific demand for virtuous character isn't a modern invention. The foundational texts of medical professionalism, written centuries ago, explicitly designed the concept of the medical professional as an antidote to self-interest.
You become a doctor to serve the vulnerable, not yourself.
Exactly.
So centuries later, even in an era of complex in utero surgeries, wildly restrictive legal environments, and the threat of implicit bias, that core legacy remains completely unchanged.
It really does. The ethical MFM clinician have to be a rigorous scientist reading the data, a virtuous practitioner caring for the human, and a committed justice advocate fighting the system, all at exactly the same time.
It is arguably the most demanding standard in modern medicine. But as we've seen, when you are dealing with the deeply interconnected lives of the maternal-fetal dyad, it is the only standard that actually works.
I couldn't agree more.
It really brings us all the way back to that broken X-ray metaphor we started with. In so much of life, we desperately look for a clean break, a binary answer, a simple picture that tells us exactly what to do.
But in prenatal medicine, the clarity doesn't come from a picture.
No. The clarity is forged through continuous, ethical, and compassionate negotiation between a doctor and a pregnant person. Which leaves us with a final thought for you to mull over.
Oh, this is a good one.
We spent a lot of time today talking about that two-variable activation chart. We talked about how, before the point of viability, a fetus's status as a patient is heavily conferred by the mother's intention, which is grounded in that intense physical, biological dependency.
Right.
But as you look ahead, as medical technology continues to rapidly advance toward science fiction realities like artificial wombs or complete outside-the-body gestation,
Yeah, coming.
how will stripping away that physical, biological, maternal connection fundamentally rewrite our entire moral definition of what makes someone or something a patient in the first place?
That is the frontier. And it raises a profoundly important question for the future of humanity.
It really does. Thanks for joining us on this deep dive.